Your time starts now. You are referred a 63-year-old lady. She is known diabetic and hypertension, well controlled with medications. Past history of myocardial infarction. 3 years back had two stents placed. The reason for the referral is visible blood in the urine. She had flexible cystoscopy which was normal. CT urogram done showed possible lesion in the left kidney measuring 10 centimeters. There is no signs of any lymph node metastasis or vascular involvement. How are you going to treat her further? Her examination findings are not significant.
Sorry, this is on ultrasound or CT finding the 10 centimeter mass.
CT urogram done for evaluation of visible hematuria.
Okay. So for this patient, I will see her urgently in the presence of the oncology nurse specialist. I will review, before that, I will review her images and make sure that she had the correct protocol for renal characterization. So I will review the images and I may need to arrange for a proper triple phase renal CT for a better characterization of the lesion. And I will arrange for a CT chest as well for a complete staging. I review the images in the MDT, and then I will review the patient in the clinic with the nurse, with the oncology nurse specialist. After that, I explain to her the finding of a 10 centimeter mass, which is high likely to be cancerous, and if the tumor according to the CT is localized and there is no lymph node and other metastases, then I will discuss with the patient the option of treatment in the form of radical nephrectomy. However, she has multiple comorbidities, diabetes, hypertension, and the cardiac stent. If she is proven to be high risk for the surgery, then maybe we will just observe, treat her palliatively with symptomatic treatment.
Okay. How will you decide whether the patient needs a separate renal protocol CT scan or we are happy with CT urogram? How will you decide that?
It's usually the radiologist who review the images in the MDT. If he is happy that he have a baseline attenuation from the renal tissue, and then after the contrast injection, he's happy with that there is a significant enhancement, and we can comment on the renal pedicle lymph node and local extension, then maybe we can go ahead with the CT urogram. But most of the time, we need a proper triple phase CT for better characterization.
Okay, so this patient CT scan clearly proves presence of possible renal cell carcinoma. And how will you evaluate her fitness?
So I will refer the patient to my anesthetic colleague for assessment of fitness. I am aware of a protocol called the CPIT, which is cardiopulmonary exercise test, which is used for assessment of a patient for major surgery. So I can refer the patient for CPIT for proper assessment for the patient, optimization during the surgery, and planning for her post-operative course, whether in ITU or in the ward, and give her a precise risk about the anesthesia and the surgery.
Can you explain the CPET test?
So the CPIT test, basically, it is done in a special department where there is a resuscitation equipment available, because there is a very, very low risk of morbidity and mortality because of the exhaustion associated with the test. The test composed of monitoring of the patient for pulse, blood pressure, respiratory rate, oxygen saturation, a 12-lead ECG, and measurement of the inspired and expired gas for VO2 and VCO2. And then the idea is that we put the patient under stress by either treadmill or by a bike. Usually it is 4 phases. Start with a rest phase, then unload exercise, and then ramping, and then recovery phase. And during that, we observe the vital signs of the patient, and we measure the anaerobic threshold for this patient, and if the anaerobic threshold is less than 8, this indicates that this patient is high risk for surgery and anesthesia.
Okay, so let us assume that this patient's CPET test shows that she is fit for anesthesia and diabetic hypertension controls are well adequate. How are you going to take it forward? Her renal lesion is 10 centimeters. How will you decide between partial and radical nephrectomy?
So, according to the EAU guideline, we should offer a partial nephrectomy for a patient with a T1 tumor, which means that tumor less than 7 centimeter. So this patient, the tumor is more than 7 centimeters, so she shouldn't be a candidate for partial nephrectomy unless the patient is having poor kidney function on the other kidney, or maybe the systemic disease like diabetes and hypertension have a potential for further renal damage. But still in this patient, more than 7 centimeter, I would consider radical nephrectomy rather than partial nephrectomy, unless it is a solitary kidney or synchronous renal tumor, bilateral synchronous renal tumor.
Okay, she has no risk factors and there is no need for any compulsive need for partial nephrectomy. How are you going to prepare her for radical nephrectomy?
So I'll consent the patient first according to the BAUS. I will use the BAUS leaflet. I'll explain about the benefit, risk, and alternative for the surgery. I will explain that this surgery nowadays is done by laparoscopic or robotic. It is associated with the usual risk of anesthesia, infection, pain, need for blood transfusion. Specific complication may include bowel injury, paralytic ileus, abdominal wall sepsis, hernia following the surgery, and in the long term, there is a possibility of deterioration of her kidney function. So I will consent her for that, and then we'll proceed with the surgery, which is done nowadays minimally invasive with a robot.
Okay. Could you explain the robot arms used for radical nephrectomy?
So the robot will be using a port for the camera, and then 2 to 3 arms controlled by the surgeon who is using the console, and the assistant will be near the patient and the nurses to insert these ports.
What is the advantage of robot compared to laparoscopic assisted radical nephrectomy or open?
There is no oncological outcome benefit. Both of them, they have the same oncological outcome. However, the robot associated with less operative blood loss, less pain post-operatively, and shorten the hospital stay. So these are the main advantage.
Okay. What is your take on lymph node dissection?
So lymph node dissection is not recommended unless they are clinically enlarged, because only 20% of lymph nodes are proven to be involved by cancer. So there is no recommendation for a routine lymphadenectomy. The only indication if the nodes are enlarged, and there is no consensus about the extent of lymphadenectomy in case of renal cancer.
Okay. So what are the indications for lymph nodes, if at all, dissection?
If the nodes are clinically enlarged, either perioperatively or in the imaging before the surgery.
What is your take on removal of the adrenal gland?
So removal of the adrenal gland is not done routinely unless the adrenal looks abnormal at the time of the surgery, or there is a direct extension of the tumor into the adrenal.
Okay, this patient has uneven full robot assisted left radical nephrectomy. The histology shows 11.5 centimeter poorly differentiated renal cell carcinoma. No evidence of any surgical positive margins, adrenal not included in the specimen. Is there any way we can grade the patient's histology of RCC?
Yes, we have previously the formal grade for grading of the cancer. Now we have the International Society of Uropathologist grading, which composed of 4 grades. So grade 1, usually the nuclei are not visible on magnification of 400. Grade 2, the nuclei are visible on a magnification of 400 and eosinophilic. Grade 3, they are visible on the eosinophilic on magnification of 100. And the grade 4, there is a widespread nuclear pleomorphism and involvement by sarcomatoid or rhabdoid element.
Okay, very good. Again, clean performance, no concerns. Only thing is, when I am discussing about how will you decide between whether to just take the CT urogram as good enough to decide about radical nephrectomy, or you want a specialized renal tumor protocol CT scan. You mentioned about radiologist, but you haven't brought in MDT. But overall, nobody will remember whatever you have missed if it is a very small things like that. If you are able to go through the same scenario again in our YouTube recording, you can see that in the second scenario you haven't really bought the MDT at any point, but it doesn't matter at all. Okay.
Okay.